Sorry, my experience with dementia mainly started in 1997 when I was first posted to a geriatric ward in Alexandra Hospital. And so there's one day it was very interesting. I was, somehow it occurred to me that half the ward were male, half the ward were female. That was how the geriatric ward in Alexandra Hospital was structured that day. And half the female patients have a diagnosis of depression, while the half of the male patients have a diagnosis of dementia. So somehow I was intrigued by that observation. So since then, I became very interested in geriatric medicine, older people, caring for older people, because it is very holistic, and that it really demands everything of you in trying to heal a person beyond prescribing medication. And over the years, I worked in Tsao Foundation in Huami Mobile Clinic, caring for homebound elders, learning from my colleagues and mentors like Dr. Marian Tsao and so on. And at certain period, I was invited to be a guest doctor, a kind of a locum resident doctor with the geriatric department. I learned from Dr. Philip Yap, who is, in my opinion, one of the best doctors caring for people with dementia in Singapore. And through a few years, and after that, there was also an opportunity granted by Agency for Integrated Care for me to start a dementia care program in where I worked. So I organized a team to take care of people with dementia in the community, and for a few years, and there were very good results, and was able to present papers locally and abroad. And so today is the culmination of all this knowledge and experience that I've accumulated, and my target is you, people who are caring for people with dementia. And when I was developing this set of slides, I was having in mind people who are directly giving care to parents or grandparents or relatives with dementia, acknowledging your sacrifices, but also families of people with dementia, families of caregivers of dementia, as well as neighbors and friends of people with dementia, and perhaps people in the community who know of people with dementia in the community. So this talk is designed for you. I've structured my talk into two parts. The first part is mostly technical, medical, a bit scientific, but I hope it is made easier to understand for you. And the second part is some very practical, I hope, advice for people caring for people with dementia. So let me just begin. So dementia is actually very common. This was a piece of survey done by Prof. Ng in 2003. That was long ago. So at that time, aging generally for developed economy like Singapore, we regard it as 65 and above. I mean, of course, aging occurs throughout our life, but just to be a bit more convenient in counting beans, statistical analysis, we put the arbitrary age at 65. So if you regard older people from 65 onwards, the rate of dementia is 6%. Above 60, it is 5.2%. So generally, if a person have dementia before 65, we consider that as early onset dementia. It has a different genetics to it and a different set of challenges. I will be focusing more on the older people with dementia today because younger people with dementia is a very challenging topic. I may not be fully qualified to talk about it. But I want to show you this one compared with the next slide. The next slide was something done in 2015, published, very important paper by the team from Institute of Mental Health, led by Professor Subramaniam. And they found that using a different protocol, which is very accurate, valid, sensitive, specific, devised by an international work group on dementia. They found that I think the number is more than 10,000 people. People with dementia above the age of 65 is about 10%. So if you compare this with the previous study, 2003, you find that if they were equal, if things were being equal, you find that there's an increase in dementia. Of course, they use a different standard, but then again, 1 in 10 is really a lot. And I'm not that surprised because from 2003 until 2015, the older person's population has grown by leaps and bounds. In 2015, 1 in 8 Singaporean is above the age of 65. And it was estimated that in about 10 years' time, 2030, it will be 1 in 4. So when there's 1 in 4 people above the age of 65, the number of people with dementia will be very big, okay? And so this just to give us an idea that that it is an important issue that we have to grapple with. In my previous post, we did the privilege of doing a survey among a group population in Singapore, older people over the age of 60. It was similar. It was 1 in 10 positively screened for cognitive impairment. So this is the magnitude of the issue we're dealing with. So just a background. Now let's talk about what is dementia. So this is from Ministry of Health Clinical Practice Guidelines. It is a significant loss of cognitive functions such as memory, judgment, attention, abstract thinking, etc., resulting in functional loss, presenting for 6 months or more. The important point to highlight here is there should be some functional loss. If a person have got some cognitive impairment, but he's able to go around doing well and able to work and, so it may not be dementia. It could be just maybe not enough sleep, maybe too much stress. Sometimes we can get very easily distracted when when we are too pressed for time, too many things to do. And then when we're very distracted, we can't focus and we tend to be forgetful. So that may not be dementia, and it should be a significant loss of cognitive function. So for somebody generally did not have cognitive function, then gradually it seems like this person is losing the cognitive function. So that is dementia for a period of time. So that's the definition. And many of you equate dementia with Alzheimer's disease. It is not exactly correct, but it is not too far off because Alzheimer's disease is the most common cause of dementia, but there are many other causes of dementia. So dementia is not technically, strictly speaking, it is not the diagnosis. Dementia is just a feature when a person has got cognitive disability, representing a loss from previous normal, and is affecting the activities of living. So that is dementia. And it can be conceived of as a kind of a disability of the cognitive function due to pathology in the brain. So if we understand, in the heart, you can have heart failure. In the lung, you can have respiratory failure. Kidney, you got kidney failure. So dementia is a kind of a brain failure. But if you call it brain failure, it's not good enough. You have to understand the underlying cause. Just like when we have a heart failure, we need to know what is the underlying cause to the heart failure. Why? Because there are treatable conditions that we can manage. So, for example, vascular dementia is due to many strokes, in the brain, so causing many injuries to the brain. And if you were to, for example, take a blood thinner like aspirin, you can halt, at least theoretically, the progress of the dementia. Alzheimer's disease is related to deposits of some protein metabolic byproducts in the brain and out in the brain cells and outside the brain cells, and that can also be treated. And other dementia. So all these are the diagnoses of dementia. It is important for us to find out what is the cause of the dementia, just like why is it important for us to find out what is the cause of the respiratory failure, heart failure, and kidney failures. And then when we treat it, we might be able to prevent it from getting worse. So it is useful to differentiate the different types of dementia for treatment and also for care planning. So many of us have a lot of concerns about whether our loved ones, the symptoms are due to dementia. So I'm going to share with you what are the symptoms of dementia. But I'm going to share with you by corresponding the symptoms with areas of cognitive impairment. So we know the brain, they've got many parts. I should have given you a picture of the brain. I can explain a bit better, but you can look at my head. Okay, so Alzheimer's disease, for example, start at this side of the brain, at the inner side of this brain, and then it progress outwards, and then go frontal, and then to the back, to the middle, and all the way to the back. The side of the brain is in charge of memory. Okay, the front of the brain is in charge of executive decision making function. Okay, visual spatial orientation, and then the middle segment in charge of language. At the back is vision. So when the dementia affects the brain, it has a certain progress, but we will not go into the progression, but I'm just going to share with you what will be affected when the certain part of the brain is affected. So when the temporal lobe, the side of the brain is affected, which is the beginning, we tend to get short-term memory loss. So how does it appear to you, to the family members? The older person keep asking the same questions, okay? Because after you give the answer, she forgot about your answer. Or that you tell her that you're coming to see her today, and then when you turn up, oh, she cannot remember that you call her, and then she may go out and buy something, but halfway she forget what she wanted to buy. Okay, then they can also have impaired reasoning. Reasoning is at the frontal lobe. So when they have impaired reasoning, what will happen? So they may not be able to handle work so well. So yeah, it reminds me of a patient I used to take care of. He was diagnosed in around early 70s. After 1 or 2 years retired from work, it was discovered because the workplace just told the family, Mr. So and so really can't work anymore, and they have been supporting him and covering his work, despite the fact that he was not able to handle. He was a handyman in a hotel, fixing locks and doorknobs and other things, but he always made mistakes and he couldn't figure out the mechanics of things. So his colleagues just have to cover for him, but they were able to sort of support him for a few years. So it was discovered a bit later. All the colleagues were like, because he was such an old friend, so they were covering his work. So he was not able to handle his work, not able to make plans. For example, say our mother, used to be able to plan a dinner, but now she find planning for dinners very stressful, and then sometimes she may not be able to, she may not want to do it anymore. And also when they buy things, so for example, they buy soy sauce and they buy many. So I got a patient whose cupboard is full of soy sauce, his fridge is full of fish. So there's some reasoning issue. And impaired visual spatial abilities is the one that's most troubling. Sometimes they wake up at home and they cannot tell where they are. So they're a little bit lost in their own home. And also when they go out the house, they can get lost in the neighborhood or in their own home. So I have a patient who walked out of the bedroom to go to pee, but couldn't find the toilet. And because he was so, urgent, so he goes to a corner and pee. And later we discover when she goes to the toilet, he saw a mirror and he see there's a man there. So he turned away thinking that was not the toilet and looking for another place. So this is visual spatial problems. And when we test the patient, we ask them to draw a clock. They can't place the words correctly, the numbers correctly. And they may not be able to recognize familiar faces, not able to read, and can only see one thing at a time, like a patient of mine. he smokes at home, and then the ashtray is in front of him, but he couldn't see the ashtray, only the cigarette. So he cannot find the ashtray, and he just tapped the ashes onto the table. And also the wife is very frustrated because she's always told him where the switch is, and then she couldn't find the switch, and is always calling the wife, where is the switch? So so these are some of the problems that they face. Okay. Then impaired language function is manifested as reducing vocabulary. So sometimes a person reduce the fluency and also number of words, and also sometimes they can't find the correct words. Some of us are affected by that too, but yeah, but sometimes because we are just too many things on our mind. Change in personality and comportment. This usually affects people with the frontal lobe affected. They may become a bit more disinhibited, may not know what is the correct things of doing things, may not ask permission and just take things. They don't intend to steal, but they forgot that they need to be courteous or polite, you know, and they have got, poor moral judgment, aggressive when not getting what he wants, not able to moderate emotions. And then when it affects this part of the brain where the motor functions are affected, they cannot plan activities. So by then, a large part of the brain is affected. They can't button, you know, the button is like all wrong. I've got a patient who wore her trousers onto the head, and then she just did not know how to put on the trousers. She put it over her head, and cannot make a cup of beverage. So these are the symptoms of dementia from the beginning, gradually all the way to when a person is overall affected. But I would like to share with you a model that is even more important. So enriched model is another way for us to understand dementia. So what I've just shared with you is the neuropathology. Okay, in Alzheimer's disease, the protein plaques deposit first in the inner aspect of the temporal lobe, then gradually spread to the temporal lobe, to the frontal lobe, parietal lobe, all the way to occipital lobe. Okay, you can see my hand now where it goes. Okay, and that's the neuropathology. And then the manifestation are the symptoms. Okay, but it is affected and moderated by a person's life history, as well as the physical and health well-being, and then the personality and the social psychology. So what do we mean? A person may have the neuropathology in different degrees. And if the person is having stomach ache, maybe due to constipation, or maybe eating too much, so not enough blood to the brain, or the blood goes to our stomach. We all experience this after a meal, we get very tired, or that they are having some pain, maybe there's arthritis, or that or maybe they're having heart failure, breathlessness, you know. So when this is not well, the circulation to the brain is reduced. And also the brain is distracted by the symptoms of the body. So they don't have enough resources to even process information. So physical ill health and unwellness, such as being too cold or too hot, too hungry, can worsen the neuropathology and make all these symptoms worse. Life history is important. So when we develop dementia, it is the short-term memory that gets affected first. So the long-term memory, like how we are in our childhood, in our youth, in our adult life, are still relatively preserved. So they can tell you long stories around maybe the World War II or maybe in the youth, but they cannot remember what you just told them. And the life history, say the life history is somebody who maybe has been a very caring, very calm and warm person. So when there's brain pathology, the habit of the life will still shine through. If the person is very warm and hearty, he'll be warm and hearty. Humorous, he'll be humorous, you know. But if a person is like a worrier, you know, they will tend to be very worried. So the life history is important. So same as the personality. Personality, they are introvert and extrovert. Extrovert, they like to meet people, they like to go out and walk. And if they are not given the opportunity to go out and meet people, they get very bored. And when they're bored, they get unhappy. And when they're unhappy, and the confusion will add on to all the unhappiness. So personality is important, and social psychology is very important here. So, and what does it mean? How a person feels is dependent on how they are being respected or communicated with or connected or being regarded. So if everybody around this person disregard the emotions, do not see them, as if there's no attention to them, the loneliness and the boredom will act up, and then the whole dementia syndrome will become even worse. So this is an important model from Professor Tom Kitwood that is something that I would like to emphasize, because caring for dementia is not just managing the brain pathology. But I'm going to use this later to talk about how, as caregiver, we take care of people with dementia. So, so if we have dementia, what are the things that should be done? Or if our loved ones have dementia, what are things that we need to do? It's better to have a diagnosis. Without diagnosis, it's very difficult for you to decide on what is the thing to do. How do you make plans? How do you even explain to your relatives or even yourself? I mean, if you do not know the diagnosis, you'll always be wondering, is my mom being stubborn? Is this the personality or is this dementia? You may not know. So it's important to get a diagnosis. Many years ago, among even my medical colleagues, many of them, sometimes they think that dementia, since it cannot be cured, there's no point diagnosing. But nowadays, most medical professionals will think that dementia should be diagnosed, because there are many things we can do, and this will tremendously improve the quality of life of the person with dementia, as well as the caregivers and the family. So making diagnosis is important. After making a diagnosis, it's not the end, because a person with dementia is not the dementia alone. You have to do a comprehensive assessment regarding the functional abilities, the vision, the hearing, whether they've got diabetes and heart disease, and how's their stamina, their mobility, any pain, and mood, and many other things we need to do so that we can set goals and create a workable care plan. Another important point is staging. Somebody, before we start the talk, asked about staging. So it is important, and I'm going to share with you in the next slide. What is staging? Dementia is not static. When we think of dementia, it is not a person who gets lost, because he might get lost today, but after a few months, this person may not be able to go out of the house anymore. So a person is very dynamic, okay, and it is changing over a period of years. So I'm going to share with you in the next slide. Medications. There are medications. If you see a doctor, he may consider giving if you have dementia, some medications. The medications generally, for dementia per se, there are two types. The first one, cholinesterase inhibitor, such as donepezil or Aricept, your rivastigmine or your Exelon, and your galantamine, Remenil. So these are the common medicine. All of them are roughly equal, and they have been proven to help a person to stay independent for a longer period of time. There's another group, there's only one representation, called Mementin. It, together with these cholinesterase inhibitors, it is even better. And Mementin itself has been proven to reduce challenging behavior. So these medicines are useful, but you won't see the effect unless you're like me. I see many patients. Those who are taking the medicine are better off than those who are not. But if you are only the caregiver taking care of mom, you may not see the difference. Yeah. Care education and training. dementia, as I said, is a disability of the intellect, of the cognition. Huh? And so if you want to take care of a person with dementia, you need to be well versed in the condition and how to take care of the person. It's and for the long haul, I'm going to in my second part, I'm going to focus on this. Then home safety, of course, and social engagement, cognitive training, rehabilitation. There's so much to say about this. I don't have the time to go through this. So generally, learning activities will be useful for training, cognitive training, any kind of learning. Learn to sing, learn to draw, learn to write, mathematics. These are all useful. And the other point is advanced care planning and lasting power of attorney. Early stages of dementia, they do have mental capacity. And if we have the opportunity, we should get the LPA documented and filed. And then we can do advanced care planning. So these are all the important elements of dementia. So that is why it is good to diagnose dementia. There's so many things we can do. If we don't have the diagnosis, the rest is a bit tentative, you know, and then we are always sitting on the fence. So this is the important slide that I wanted to say. It's a bit busy, but let me walk you through. There are many staging systems, but the one that's commonly used in Singapore is FAST, F-A-S-T, Functional Assessment Staging. Okay, and it is based on a function. There are 7 stages as a person develops dementia. For most of the years, because dementia occurs in the old age, for most part of a person's life, he's normal, but he started to have deposits of protein byproducts in the brain, and then they started to have subjective memory problem for 15 years. Okay, and then this duration are all estimation, and then in stage 3 we call them mild cognitive impairment. They are still very functional, but it's just that they are finding employment becoming more and more challenging, and they can last at this stage for a while. Okay, and then they develop further. After roughly about 7 years, they start to have dementia. So between 3 and 4 is the watershed. 3, you haven't got dementia yet. 4, technically we consider that is dementia, but 3 is a pre-dementia condition. There are some studies that show that even at this stage, it is good to treat and start cognitive training and other lifestyle changes to delay the onset of dementia, and they can still function independently for a long time. But 4 onwards is dementia. So I just go through fast. 4 onwards, they can't do complex tasks like planning a dinner, handling finances. Okay, they last about 2 years. 5, they need assistance in choosing the proper attire. So around late 4, early and early 5, they start to go out, and sometimes they take a long time to return home or find their way home. Then they develop gradually until stage 6. Stage onwards, they needed help in the basic activities of daily living. From beginning, they lose their ability to dress themselves, to bathe, then not able to handle the mechanics of toileting. They started to develop urine incontinence and fecal incontinence. So that's stage 6. Then stage 7 to stage 7F. This is called severe dementia. Stage 7, the words is limited to at most 6 a day. Stage 7B, only 1 word that is understandable. And then stage C, they are not able to walk anymore. D, cannot sit up anymore. E, cannot smile. F, cannot hold or move the head independently. And these are the rough estimation of number of years. So you can see from stage 4 onwards, it is roughly around 10 to 15 years. Okay. I have a patient who was given anti-dementia medication, and she was still able to walk after nearly 20 years. Yeah, she was in her 90s when I see her. So this is the staging of dementia. It's useful for caregivers to understand the gradual loss of function so that you can make plans. Dementia can be prevented, Alzheimer's disease. So why I'm bringing this slide is that even if anyone with dementia, we still have to do lifestyle factors to prevent dementia from getting worse. So what makes dementia worse? Genes you can't change, right? But you can avoid alcohol, unhealthy diet, which is high in saturated fat, obesity, diabetes, hypertension. Once you get it, of course you have it, but you can control your diabetes, hypertension, and cholesterol. And vascular insults is minor stroke. So if you're prescribed medication to prevent stroke, you should take it. And of course, you can also exercise. Higher level education can protect against dementia. Cognitive training means any learning like what we're doing now is cognitive training. Social activities, basically, loneliness is a risk factor for low mood. Low mood is a risk factor for dementia. So we want to keep the person's mood good. Okay, so avoid loneliness, social activities. So these are the protective factors. And then useful resources, Alzheimer's Disease Association and Agency for Integrated Care. You can search for AIC under dementia. There are lots of resources for caregivers. So I'm going to just have a midpoint reflection. Then I'm going on to the caregiving for caregivers. So first point I want to emphasize is that forgetfulness may not be dementia. Suspect dementia if it affects our daily living activities. So if it does affect the daily living activities, it is good to see a doctor because diagnosis of dementia by a doctor is the first step in decisive care planning. Knowing the trajectory, the staging of dementia is useful in care planning for the long term. Medications can be useful in preserving the function of daily living. Other useful activities include health promotion, such as diet, exercise, social connectedness, and pleasurable activities, which I've just covered. Home safety, health monitoring, preventive health, chronic disease management is also necessary because the person with dementia is not just dementia. Okay, cognitive training through learning and games. Okay, ACP and LPA, advanced care planning and lasting power attorney, and care partners, which is ourselves. We are the partner of the person with dementia, and the person with dementia is also partners to us because we're caring for one another. So I'm using this term called care partners. You should connect with resources such as AD and AIC to learn more and access a lot of resources. Nowadays in Singapore, there are many resources and schemes caregivers can tap into to help in the care of persons with dementia. Okay, now I want to talk about care. If you are taking care of somebody with dementia, you may want to pay more attention here. So this is a quote by Dr. Bill Thomas, a geriatrician who founded the Eden Alternative culture change process, which is a systematic way to deliver person-centered care. And because of him, there were new ideas related to the design of nursing home in America. And he defined care. To care is to help another person grow. So yeah, so it's a very interesting, so think about it. So to care is like growing a plant or a garden. You know, you need to help the plant grow. Okay, so say if you're a care partner and then now you have a father or mother who behaves as if they're very stubborn, you know, very difficult, or they are like I have a patient who would hit you when you want to shower him, or that they scream and shout at night or at the door, saying that they're being locked up by people in the evening period, sundowning. So what do you do, right? So I've improvised a checklist. I must acknowledge my friend, Miss Jane Verity, Dementia Care Australia, is inspired by her work in Spark of Life. The first thing is there's a challenging behaviors that you're confronted with. You can ask yourself, does it really matter? You know, like for example, a person is like wandering around the house, walking. Okay, does it really matter? Maybe it doesn't. You know, it's just wandering. People need to exercise, need to walk. But maybe it does matter because normally he doesn't. Today suddenly walk a lot. You know, what is bothering him? But this is his routine, then it doesn't really matter. Okay. But of course, sometimes if it creates danger or is a manifestation of a person's unhappiness, then maybe it does matter. So you have to ask yourself. And the next point is use our hearts and not our brains. I have to say, in the caring for people with dementia, using our hearts and not our brains is very, very important. Okay, you will gradually understand that the mind is not only the brain. The brain is only an organ. The mind is the mind. And if you understand this, you will realize that our parents, despite the brain failure, they are still our parents. The mother is still there. The mind is still there. The habit, the personality is still there, and they can still feel. But anyway, we're talking about our being a caregiver, right? Because if we use our brain, we can't understand. We have to use our heart because they got a brain failure. So if you want to understand them, you have to use your heart because their heart has not failed yet. So you use our heart and not our brain, and we put ourselves in their shoes and see the world from their worldview. Okay, this is a very important point because in order to care, we need to accept and understand. In order to accept, we need to understand. So in order to understand, you need to put yourself in their shoes and don't use our brains, use our hearts, using our intuition, almost like mind reading. And once we are there, we will need to understand all these as helplessness. I have a professor of psychiatry from Australia who said something very important that I felt struck a chord in me. Just as we don't blame a person with stroke for not moving one side of the body, we cannot blame a person with dementia for behaving that way. We can only understand that they are helpless, because it is a failure of the cognitive functioning of the brain. So first we understand it as helplessness, and then we need to consciously decide to care. Sometimes we become so automatic. We may not care and we just do activities. When it happens, it doesn't have the feel, the connection, and the person can feel that you are not there. And then you cannot communicate, cannot connect. And whatever you do may not work. So when you care for somebody with dementia, you need to connect. So you need to decide to care and radiating love quietly. This is it's very funny, right? It's mysterious. There was once I have a patient who has got Parkinson's disease, and he called me and saying that he was in distress. And I went to his house, and his mother was even older, in the 90s, sitting on the sofa, was sleeping. And his house was very funny. The whole floor was wet. And he was topless. He was just very agitated because he says the neighbors is like making all sorts of noise. And he wanted to hurt them. So I went to the house, and I went to the room and found that the house, the windows are all painted. It's all very funny, and the bed was filled with things. And then there was anyway, I cut to the chase. He was very aggressive. What I did was I was sitting down there and just radiate love until he quieted down. So it was really quite a scary experience at that time, because he's a bulky man in the 60s. He was finally I managed to send him to the hospital. He okay, then the next point is, after you understand and then you decide to care and then you radiate your love, you need to use your mind and to ask yourself, what is her unsaid needs now? Because they cannot speak very well. So they're just pacing away, or they're very aggressive, like what I was telling you. What is the unmet needs at that time? So you need to feel. And after you know the answer, you respond accordingly. So I'm going to elaborate on the fourth point. What are the unmet needs? Everybody has got physical needs. Is it hunger? Or is it pain? Too cold, too hot, too itchy, too dizzy. So like caring for a baby. I don't mean our seniors to regard them as our baby. I'm just using the technique of a mother taking care of a child who can't speak. So a son taking care of the mother who can't express herself. We have to use our mind to understand what are the physical needs that is bothering. Maybe it is hunger, maybe it is pain. And security, maybe it was due to the darkness of the house or the sunlight dimming, and then certain kind of noise, and the person is confused, disoriented, or that he's feel unsteady, and then unfamiliar environment, they can feel insecure. And when they're insecure, they can also behave in very challenging ways. And finally, once you have settled that it's not security issue, it's not physical issue, it's probably emotional issues. When a person is emotionally unsettled, they can feel bored, they can feel lonely, they can feel helpless, they can feel unhappy. Just like us, when we're unhappy, what do? We we surf the net, we watch YouTube and just play computer games or just do all sorts of things. So, but if you have dementia, you can't do all those things. You still have to manage your emotions. And what do? Some of them would be peeling, some moles, scratching, or they may be plucking the leaves off the trees or the plants in the house. So all these are real examples. So there are all these unmet emotional needs. So there are 5 universal emotional needs devised by Miss Jane Verity, which I find very useful. All humans need to be useful, need to be needed, need to love and be loved, need to have the power to choose, and need to have the self-esteem boosted. So backtrack a little bit. So does it really matter? Use our heart, not our brain, put ourselves in their shoes, understand their health business, consciously decide to care and radiate love, and feel what is the unmet needs. And then go through this list. So a lot of time, people need to be useful, to do something useful, and to feel needed, feel appreciated. People be thanked, appreciated. People feel grateful for your care and sacrifice. Feel love. There are many love languages: gift, food, hugs, words, service, and they want to also give back. So when a patient, when some of the older persons I see, they give me a cup of tea, I will accept, because everyone needs to love and be loved. The power to choose, even if there's no choice, you still give them a choice. Like, would you like to wear this or this? At least there's a choice. Would you like to have your lunch now or 5 minutes later? So always give people a choice. Self-esteem is always, nothing is wrong, everything is right. Always celebrate successes. So praises, so for persons with dementia, these are emotional needs that if you know, when a person is agitated, you can just sit and feel, oh, I see, now he is very bored, want to be useful. Like a patient of mine who would tear his own diapers and put it in the washing machine, and the wife is very stressed, but actually he's trying to help. He's trying to help the wife. So you have to see what is the message behind it, and then you can do accordingly. But to break down challenging behaviors is not enough. We want to prevent it. So just now I talked about when you're faced with challenging behaviors, what do you do? And then ending up with trying to read their minds. What is the unmet needs, right? But after this is resolved, you still have to find ways to prevent challenging behaviors from occurring. So this is through performing activities that instill joy and happiness together. So just like all of us, when we're working, we find our life is very meaningful, very fulfilled, and we got lots of things to engage. And sometimes we can be stressed. That's when we're overworked, but there's something to occupy. But when there's nothing to do, we can really get very edgy. Same as for our parents who have been housewife or been the breadwinner for the family. So we need to have activities that promote emotional well-being. So we need to know the person. So say you've got a mother or father with dementia and you want to occupy the time, don't just turn on the TV and watch, because it's very passive. So you need to know the person. What's the life history, work history, what are the hobbies, what do they like and dislike? And what kind of engagement do they have? What do they do around the clock during the week? and what are the abilities and limitations like hearing, vision. Can they do simple things like plucking the taugeh, you know? So what are their abilities and what they can't do? Sometimes we may not know, so we have to try and error. But this is to know the person first, and then we explore activities that are enjoyable, relaxing, appropriate to their abilities. Don't make it so challenging that they fail. I think it's very unhappy. But make it so that they're appropriate, and then they feel, hey, I can do this. You know, it's good and it's meaningful to the person. Yeah, meanings, there are many levels. So some people find playing with dolls very meaningful because it feels the kind of it meets the need to love. So there are person with dementia like stage late 5 or 6, they find doll is very useful. But if you give it to somebody stage 4, oh, why are you giving me a doll? You know, so you need to find the appropriate things meaningful to the person, and then you make journals because this is a learning journey. Planning activities together, caring for a person is a learning journey. So how do we, okay, what kind of activities? Okay, there are activities of different level, from the most complex planned activities with a goal, or exploratory, just not so much, yes, it's a multi-step activities, but not so much the success of the goal, but more the experience of the journey is interesting. But when a person is a bit more advanced in dementia, then it's about sensations of the activities, you know, like sweeping the floor or gardening, feeling the soil. But finally, when a person is severe dementia, it's about sensory stimulation. When the person is dementia, advanced stage, they just lie in bed, not much of stimulation. So sometimes we like to have very interesting smell for them, or massaging the hand with emollient. So examples are cooking and baking. You know, they can plan house chores together, sewing and knitting, depends on the person's interest and life history. Going through old photos and tell stories, or just mere storytelling is fun. I got patients whom we have got volunteer students and just write the life stories. It's all very interesting for people with mild and moderate dementia. Eating durians is very good because there's a lot of texture, and the smell and the taste is very, very stimulating. So much happiness. You know, there's once my boss belanja everybody to a durian party. So much laughter and joy, and we really observe when there is happiness, you can't tell who has dementia, who does not have. Okay, so durians has got high potassium, high fibers, high vitamin C, a lot of calories, good oils, unsaturated oil. So it's very useful. And but if you have got diabetes, then you have to eat less. But durians is good for people with dementia. And it's very easy to, you don't need teeth, and it's very easy to swallow, even if you've got this discoordination of your swallowing. Coloring, you know, coloring, no wrong, everything is right, just very beautiful. I have a patient, you know, coloring the peach, and then he call it the buttock. He's got advanced dementia. Cats, dogs, fish. Okay, there's a study that I saw from Japan. They use aquarium watching goldfish, improve the quality of life of a person with dementia. Bird songs, dogs and cats. Dogs are very smart. Cats are smart, but in their own way, and got texture, and they're cute. Okay, hand massage, foot massage. All these are good activities. Everything is right, nothing is wrong. So we don't want people to feel frustrated. All the activities should be suitable for their abilities. And when you write journal, how do you do? So 24, if you're a caregiver, you may want to do this systematically. Write down what the activities, what are your observations. Maybe like get up from bed, eating breakfast, then took 2 hours to eat and fall asleep. Okay, then 9 o'clock, watch TV, sleep while watching TV, having lunch, take 2 hours, and so on. Or maybe started to get angry, frustrated, spitting the food out. Okay, so we can write the observations. Then we analyze what were the physical states, the mind states, and the behaviors of mom, of interest. Interest meaning of concern, either something that you're very concerned about, or something very interesting that you're very happy. Oh, this is a success. Okay, so even if it's successful, what are the causes and what were the consequences? So, for example, when I have a patient, she went to church. There is some activities developed by Alzheimer's Disease Association with some religious organizations. So it's a Catholic church. In the daytime, it's actually quite free, right? So they take care of people with mild to moderate dementia. And when they were there, they were so peaceful and they were so happy. So you can see, oh, they go to church and so happy. So what's the consequences? They eat more, and they can walk. Previously cannot walk, but now when they're happy, they can walk. So these are the observations. And then you can say, what have I learned? What shall I try tomorrow? So sometimes it's negative activities. A person is agitated. You also find out what's the cause, what's the consequences, and then what have you learned and what shall you try? You can use the checklist I mentioned to you just now. This is very important, self-care for the caregivers, because happy people make others happy, unhappy people make others unhappy. And it's useful to create routine with some me time, but be flexible about it. Always have some me time. Get all the help you can from Alzheimer's Disease Association, Agency for Integrated Care, from your doctors, from your family, from your friends, from the internet. So as much as possible, involve people. Don't feel paiseh, don't want to say, because yeah, who cares, right? I mean, we want to involve others because it's good for them to take care too, right? Not just ourselves. Do everything slowly, because when we are doing fast, we get agitated easily, and then it will show as bad mood. So do everything slowly. Slowly, you don't make mistake, and also more observing. You can observe better. Apply checklist when facing behaviors concern. Okay, just now the checklist was for the person with challenging behavior, right? Apply upon yourself. Okay. What did I scolded my mom. Okay. Why? What happened? Does it really matter? Oh, yes, it does matter. I feel bad about, throwing my mom. Then shift, share, shine. So you consider, don't use your brain, use your heart. Oh, yeah, I was feeling frustrated, and then you understand, oh, yeah, I am not perfect. I was expecting her to do this, but I forgot that she's got dementia, and so on, right? So you start to forgive and understand and accept yourself as you are, and decide to care. And then you radiate love to yourself, and then you feel what is the unmet needs. I need to be appreciated. I need to have self-esteem boosted. I need to have the power to choose. I need to love and be loved. I need to be needed. I need to be useful, and so on. So maybe, yeah. So you start to understand that, and then you can, and then you respond accordingly. So that's checklist when you have challenging behaviors in yourself, and then you also apply the perform activities that instill joy and happiness together with yourself. So what are the things that make you happy? Your life history and your work and so on. So what gives you joy and meaning? Yeah, so go and do it. Okay. So always take time off. Then you can care for your parents longer. Okay. Stay connected, learn new things. Okay. Especially now during COVID-19, I think a lot of people feel very disconnected. Very important. Stay connected. Have a plan for long term. Okay. Understand the trajectory. Do ACP, LPA, and then involve your families and plan long terms. Finally, I want to say that caring for dementia is not just for a single person. So I have the privilege of being involved in the developing of ISO standard on dementia inclusive community. And so we analyze stakeholders and what are various dimensions. So I'm just sharing with you my thoughts that I shared with them as well. So the people who care for dementia is not just the older person and the care partners, also the families, neighbors, and friends, and then also the frontline care teams like your GPs, your care managers, the social worker, the nurses, and not just them, the supporting agencies like AIC, like URA, HDB, they need to design the houses, the community, the gardens, well, the LTA, your pathway to the MRT, to have lived and so on. And so members of the community, we all need to have understanding that dementia is everywhere and among us, and they are just having cognitive disability. Okay, and we and social psychology. If we behave, if we alienate them, they will feel very insecure and then they will really act up. But we embrace them and then we are like friends, we are equals, then they will they'll become equal, they'll be like us. And so, and it's important to involve systems influencers, when I say influencers, I mean the leaders. Leaders need not be political leaders. It can be anyone, social service, civil society, internet influencers, media, all of us among our friends are influencers. And then we change the culture that we can all understand dementia as part and parcel of human existence, and that all of us are susceptible, although not all of us will get it. But we need to understand it is an invisible disability. And then when we plan for the whole society, we need to consider the whole stages, all the 7 stages of dementia that I talked to you about, the staging, the fast staging, right? And then in all the various aspects of human life, health, daily living, social activities, and work, leisure, growth. And you must think in terms of people, process, places. So this is a relatively technical slide for town planning, urban planning, and policies and so on, just to share with you, to drive home a point here. Okay, conclusion: dementia is common, 10%, especially in the fast aging population. In the future, it's even more. It's 2015, 10%. Dementia is a disability caused by the biological processes in our brains that affect our intellect. Its manifestations are influenced by emotions and past conditioning. Remember the enriched model I shared with you with the circle. To care is to meet the needs in order to help the person grow. Bill Thomas. Caring begins with understanding the person and the needs. You need to understand the person. You have to use your heart, not your brain. As care partners, we are not perfect. We have our own needs too. So we ourselves are also person we need to direct care towards. And we also need to use our heart, not our brain, to understand the unmet needs and meet the needs. The care of people with dementia is so much easier if the whole family, the whole community, and the whole society come together as care partners. So the purpose of this talk is not just for you who are caring for dementia. I'm also hoping that we can raise awareness and the whole society and the community can come together to take care of people with dementia, making it easier for caregivers, So finally, just a few words from my colleagues when we were caring for people with dementia. So this is from Mark Twain. Kindness is the language with the deaf, which the deaf can hear and the blind can see. And this from Samantha, my wise colleague, ex-colleague. Kindness is a language even people with dementia can remember. How true, right? This is another colleague. When everyone is happy, you can't tell who has dementia and who does not. It's very true. We organized a Valentine's Day. I was not the doctor. They were caring for them, and I got all these couples. I can't tell who have dementia, who have not, because all of them are singing and laughing and smiling. So that's the end of my presentation. I shall take question. Maybe Yue Peng can help me to moderate.
Thank you, Dr. Ng, for that wonderful presentation. Okay, let's go to our Q&A. Yeah, so that was a really wonderful presentation. So many touching moments and important reminder for us. We don't blame persons, as Dr. Ng has said, with stroke for not being able to lift one side of the body. So why would we criticize or blame persons who have these behaviors of interest? Some call it behavior of concern or behavior and psychological symptoms, but I like the term behavior of interest. So right now we're going to take questions. So please do enter your questions into the Q&A box. Let's start with the simple questions, technical ones, then we go to more interesting stories and anecdotes. So one person is asking about progression. At stage 3, if you learn new things, can it help to reverse or prevent progression to stage 4?
Stage 3 is mild cognitive impairment. Can we prevent stage 4 from rising? There are research, I've heard presentation on it, that MCI, mild cognitive impairment, can be, you can do things so that it doesn't progress to stage 4. Example, cognitive training, improve your lifestyles. Particularly there's a research from Finland, very important. They call it FINGER, FINGER. Some of these agency research usually have mnemonics, and it talks about certain kind of diet, polyunsaturated fat, exercise, Mediterranean diet, certain vitamins, but not individually, but combined, and cognitive training, physical activities, social connectedness, happy moments, all these can prevent dementia. And for people with MCI, you can delay it from progressing to stage 4. And also recently, some people are saying about even taking cholinesterase inhibitors, the medicine we typically give for people with dementia at MCI stage can delay. But I am not sure whether it is caught on by the rest of the professional body yet. If you do have MCI, if you do have cognitive impairment and doctor diagnosed MCI, you can check with the doctor whether anything you can take to prevent it from getting worse. Okay, so that's as far as I can answer that question. Yeah.
Thank you, Dr. Ng. There's one question about participant's relative. After finding a hole in his brain through a CT scan, does that type of condition possibly lead to dementia?
Okay, hole in CT scan depends on what we mean. So I think maybe we're talking about many areas where the brain have tiny strokes. Because in the radiology report, they call it lacuna. Lacuna like patches of tiny holes. Okay, so that is related to poor blood circulation in the brain. So some part of the brain have got minor stroke. Sorry, Yue Peng, what's the question related to this?
So the question was just whether it can lead to dementia.
Yes, okay. So dementia is a syndrome, whether the person has got cognitive impairment that affects the function. Okay, a person can have multiple stroke and still able to go about the daily business. So you don't say this person has got dementia. But if the person have got dementia and then you find that you have got this cognitive impairment that affects the function, right? And gradually, and at least for 6 months, and it's a loss from the previous functioning. That's a diagnosis. And then when you do the scan and you find there's multiple holes, then if the clinical presentation is abrupt, gradually decline, then a doctor generally will attribute the dementia to the holes. But if there's no dementia and the CT scan found there are many holes, it happens too, and we can't say those holes have resulted in dementia.
Thank you, Doctor. Could you share more about the current tests available for dementia? Someone is referring to MRI and psychological tests. How accurate are these tests? Are these the only tests?
Yeah. So the diagnosis of dementia is a clinical one. There are a few things that you must satisfy. The areas of cognitive loss. Memory is an important one, but not. But some dementia may not have their memory loss in the beginning. But generally, most dementia have memory loss. So you have to check those things. In order to check those things, we usually need to have a psychological test, something objective, something that's quantifiable. The most commonly used is mini mental state examination, MMSE, and also MOCA, the Montreal Cognitive Assessment. That's the one with many animals, and recently there's a very important political leader and he showed that he got full marks for it. So that's MOCA. That's a common use tool. Other shorter one like AMT, abbreviated mental tests, or ECAQ, Elderly Cognitive Assessment Questionnaire. These are shorter, less accurate. Sometimes a person without dementia can score low. Some people got dementia can score high, but generally they're still relatively proven. So these are the various psychometric tests. Okay. As I said, most people use MMSE or MOCA. So that is a psychometric test, and then correspond with the general symptoms. But a doctor will have to do more. We'll need to do blood tests, to check whether there's a thyroid problem, whether there's vitamin B12 deficiency, folic acid deficiency, maybe calcium, calcium level too low or too high. And then we want to do a scan just to see whether there's maybe a brain tumor can mimic a dementia. Sometimes there is a multiple stroke, then we know, oh, this dementia is due to stroke. Sometimes from the brain imaging, we can see a certain part of the brain is very small. We can say, oh, this one could be Alzheimer's. So all these tests are all important. Together, we make a diagnosis. Some people have present with dementia, but you find that the thyroid hormones is too high. You treat the thyroid hyperthyroidism and the dementia improve. So that's not Alzheimer's disease. It's just hyperthyroidism manifested as cognitive impairment. So all these tests are all important. You can't say one is more important than the other. So dementia assessment is multi-modal and multiphasic, and it comprises many areas to test.
Thank you, Dr. Ng. For those who are keen, do read up the ADA resources and also AIC resources on what the symptoms are. If you want to do a dementia screening, Brahm Centre can do that for your relatives or the persons you're concerned about. This is a screening, not a diagnosis, which is the next step that Dr. Ng has talked about. So you can always write to Brahm Centre's email to arrange for a screening. I'm now going to move on to a different question. So this person has talked about her mother, and she says that her mother has early stage dementia, currently with AWA daycare for more than a year. And the mother is obsessed with keeping the fingernails and toenails long. And the family is very concerned about the mother flipping her nails and then exposing the flesh, especially because the mother is diabetic. The issue is that the mother thinks that she has no more hair and nails, that she's not able to really reason that her nails and hair are still there. So they're having a lot of difficulty persuading the mother to cut the hair and toenails. What is particular about this case is that the family has realized that although there'll be shouting matches and tears whenever they arrange for the mother to cut her nails, they realize that they lavish her with praise. That means they give her a lot of praise whenever they have to go through that process. And they realize that the mother strives on praises. So I just wanted to share this anecdote because when I read this story, actually the participant is experiencing a lot of grief and stress, but they actually have developed this insight as to what works for the mother, which is the strategy of praise. So actually that is quite good progress in my opinion. But this person would like to know what else can be done. How can we get the mother to go for the nail cutting easily?
Yeah. So so the checklist, the first thing is, does it really matter? Okay, so you're worried that it will flip, right? How likely will it happen? Yeah, the fingernails is not so risky. Sometimes we need to see okay, before that, does it really matter? Maybe the food it matters because we know that she's got diabetes, right? But also how poorly controlled, well controlled is the diabetes. So that's one thing, right? So, but if you conclude that yes, it does matter, then the next thing you need to do is to use your heart, not your brain, to use your heart to feel for your mother. Why is she so adamant about keeping the nails? And that's when we can recall her youth, her life, her work. What was she like? I have a patient who is stroke, and then she get very happy when we do grooming for her, combing, nail polishing. So maybe to her, long nails have certain meaning. Maybe it's of beauty, it's of grooming, it's self-respect. So we have to use our heart, not our brain, and then just put ourselves in her shoes. And you mentioned the insight about grief and loss. I think that was very insightful. Indeed, some people, when they are suffering from grief, they hang on to anything because they always think that once they lose it, they'll never regain. So, so that could be the thing. So we have to address the grief and loss. Grief and loss is unhappy feeling, so we can replace it with happy feeling. So, so you can using that method where you empathize and then understand the emotions behind it, decide to share your love and care, and then you feel what is the unmet needs. So maybe nails and fingers, nails and toenails is a kind of beauty in her opinion. She like to groom it. So maybe it's about self-esteem. So we need to praise the person. We need to groom the person. Maybe we can go for what do you call that? Makeover, Then using the makeover, we can trim the nail, file the nail a little bit, but not totally cut it, but just making it nicer. So maybe it's self-esteem, maybe it's choice. Would you like to cut your nail? Would you like me to cut maybe just just a bit of it, or just filing will do? So give people a choice, not deprive them of choice and just cut their nails. And grief and loss is also related to grief and loss of memories of love, of loved ones, and so on. So sometimes we really need to create an environment where love is everywhere. And so how do you do that? So it depends on her life history. So praises, food, everybody answers to different languages of love. Some people need physical touch. Some people like food and soups, So we do that, and the person feel needed, useful, loved, opportunity to love. Self-esteem is strong, choice to choose, and then we might be able to overcome this. Sometimes we can't. And if we can't, then we have to live with it. So how do you prevent the diabetic foot from having an injury with a nail like that? So perhaps we can use protective footwear. Perhaps we can make sure the diabetes is well controlled and the house is no chance of injury to the foot or the toes. So it's important to know that not every challenging behaviors can be resolved. Oh.
Thank you, Dr. Ng. This person has a question about SSRI medication. It has been successful for her mother so far. Is there a time that she might stop taking the medicine, or it has to be taken in the long term?
SSRI is an antidepressant for depression. A lot of people, once they have got cognitive function loss, they don't have the way to control their emotions. And many people, they actually have got anxiety, maybe got low mood, but for over the years, the brain is able to suppress and control. But when the brain is failing, as in dementia, they will surface. And when they surface, their worry and anxiety, they don't know what to do. So they have got challenging behaviors, agitated, maybe they are violent, even hit you and they scold you. Then the treatment is antidepressant. Antidepressant is a relatively safe medicine. So now we're talking about depression. Depression in older people, generally, we take it for at least 6 months, and then we want to withdraw. We have to cut down slowly, not abruptly, because it will have a relapse. Generally, once there is a relapse, we will take for life. But even when we say for life, it is not really for life. Why? Because dementia is dynamic. It will progress further. So maybe now your father has got mild dementia and he's frustrated, he's disappointed, and he's insecure about his own cognitive function. So his anxiety is acting up. So you need to take SSRI. Then maybe when he progressed to stage 6, by then his brain is not able to remember even more things, and maybe some other old habits and personality will shine through. Maybe he become calmer. And by then, perhaps we can start tailing off the anti-depression medicine again. So that's my answer to you about can we stop antidepressant? Generally, first relapse, we usually cannot stop, but dementia progress, we can still stop, but have to stop slowly.
Thank you, Dr. More technical questions. Can we get, or admin questions, can we get the lasting power of attorney at stage 3 to 4 dementia?
Stage 3, no dementia yet, definitely. Stage 4, usually still can. Because LPA, you only need to have the mental capacity to understand the purpose of that document, okay? And who you want as your donee. And if the person can give reasons, then I don't see why not they don't have mental capacity. They can still have mental capacity at stage 4, even early stage 5. But when they are stage 7, of course they can't. 6 usually also they can't.
Thank you, Doctor. One participant asked about how long diagnosis takes. So I just want to respond first by saying that if we do the screening if someone does a screening for you, it is on the spot. The abbreviated mental test and the MMSE will be completed within a session or 2. But Doctor, how about the subsequent diagnosis?
Okay, so the diagnosis after the psychometric test is done based on the score, like if the score is very obvious, like 14 upon 13, say in MMSE, then I'll ask the family about the symptoms, whether is there a decline, and what are the function affected, and then I'll ask about whether they've got memory problem, language problem, procedural memory problem, recognition problem, decision-making, executive function issues. And if they are all positive, I will do a blood test to exclude the biological causes. The blood test take 1 day to turn around to the clinic. Then I will also send the patient for CT scan or an MRI of the brain. This depends on the appointment of the radiology clinic. Sometimes within the same day, you can get it done. So if we are all very vigilant about it, blood tests, the brain scan, the next day we can get everything and then we can make a diagnosis whether there is or there isn't. But the limiting factors are the appointments.
Thank you, Doctor. This person is asking, how do we help our families and the community to understand dementia? It can be challenging when we go out and then the sales staff might scold the person or people with dementia.
Yeah, I think it is not your job because it's it's public education, to sales staff and to others. You can say, sorry, my mom has dementia, but say in a very nice way that doesn't, make your mom look bad. But, and then the sales staff, maybe they know about dementia and then they can go and read up about it. So, but if we were to explain dementia is this and that, I think maybe your over teaching may not be appropriate. You can just say, yeah, sorry, my mom has dementia. And then they will say, oh, dementia. As long as you're very polite and respectful, they will realize that dementia is something I need to know about. And then they will go and read up about. But nowadays, many people are caring for their seniors. You may be surprised that every other person is caring for somebody with dementia. So many people will understand. Yeah.
Thank you, Dr. Yes, I think we have come some way in terms of dementia recognition, and I hope we continue to make progress. So there's this person who is facing challenge getting his or her father to be tested and diagnosed for dementia. So the father refuses to visit the hospital, but the child suspects that he has mild dementia. Some of the symptoms are being verbally abusive, memory loss, and noticing that he has worsened since taking medications for other conditions. So how can we encourage such persons to get the screening?
Yeah. So if they do not want to be tested, they may have their own reasons. And then you can observe you can observe the behavior and the symptoms. And the next time when the doctor see when your father see a doctor for other chronic diseases, you can raise it to the doctor that your father have got these symptoms, and then the doctor may say, there's some concern about memory. Can I do a test? If your father refuse, then the doctor also shouldn't do. Okay, so yeah, so we just need to we need to get the person's permission. So how do we get the permission? Uh, but observation of your father need not, you don't need his permission, but to get him to be diagnosed, you still need his permission. If he doesn't want to be diagnosed, then you go through the checklist that I gave you. What is the unmet needs? Use your heart, not your brain. Some people don't want to know, you know. And does it matter? Maybe it doesn't, you know.
Thank you, Doctor. We have a few minutes left, so I'm going to use this to explore some of the cases that are on the Q&A. So this person's mother has intermediate dementia and she's rattling foul language during most activities, even in the toilet. So how can we help her? Why is that? The mother doesn't know that she said those things.
Yeah, so same. Does it really matter? If she's rattling foul language and it's only you there, it doesn't really matter, right? Maybe if there are children there, then maybe it matters. But if you were to educate the children, maybe also it doesn't matter, right? But if the foul language, your mom really is agitated, is very unhappy, then it's not the foul language that's the problem. It's the mom's happiness is the problem. So what is making her unhappy? So you have to use your heart, not your brain, decide to care, start shine your light and radiate love. And then you start to feel, you know, what's the unmet needs? Is it physical? Is it emotional? Like, is it security or is it emotional? What's the unmet needs? Then you design activities that she's happy. You mentioned that when she's even doing activities, she's fouling. Maybe the activity is not suitable. The activities is too challenging, too difficult, or it's just not her cup of tea, you know, like child's play. She's not a child, you know. So maybe what are the activities that she likes? So you have to explore. So write the journal of the activities and observations, and then what is the causes, what are the consequences, and what are your learning, and try something new the next day if it's not successful the first day.
Thank you, Doctor. One participant is asking about her grandma. They're quite worried. The grandma is 72 years old, diagnosed with early dementia, can function, eat, drink, etc. Sometimes she can get up slowly from the chair and then she will hold nearby tables to support herself. Sometimes she stands up from the chair without holding the table, and she does it with confidence and very steadily. Does dementia affect her movement, her stamina, and getting up from the chair?
Dementia affects our movement and function as much as brain affects our movement and functioning. But movement and functioning is not just dementia, it's also vision and hearing, it's also muscle power, it's also your stamina of your heart function and your lung function. So, so maybe like you're saying that sometimes very, very slow, but sometimes very, very brisk. So maybe her muscle and the heart and lungs are fine. Maybe his vision and hearing are fine. It's just that maybe on days when his brain is functioning well, for example, not affected by hunger, not affected by constipation, have a good rest. In the morning, you know, they tend to function much better. Then the whole function is good. But maybe in the evening or after a meal, or maybe a bit more drowsy, or maybe having arthritis, then they walk a bit slower. So if a person with dementia is walking a bit slower, seems to be a bit more careful, it is good to have an assessment of the vision, of the hearing, of the muscle function, of arthritis, pain or no pain, heart and lungs function. If everything is fine, to promote the the safety, we always want them to go for exercises, particularly strengthening the lower legs. And then they are safer, and maybe make sure the eyes and ears are functioning well. And also, if you observe, morning they function better, evening not so good. Then evening time, more supervision, more support. Morning time, you can have less supervision and less support.
Thank you, Dr. Ng. The next question, we know this is not may not be your forte, but I wanted to ask about early onset Alzheimer's for a person who has this at age of 53. It is moderate stage, but it seems that the deterioration is quite quick. So for early onset dementia, is the deterioration much faster than old age dementia?
I'm not sure about this. Early onset dementia has a okay, I do not know whether is it faster than older persons, but I do know that NNI, the National Neuroscience Institute, has a specialty team to take care of people with young onset dementia, and it is good to find out what kind of resources available there to help you.
Thank you, Dr. Ng. We'll end off with this last question. So we are wondering, what is your take on integrating senior daycare with childcare centers? Maybe you could answer this question from the perspective of mental wellness.
Yeah. Do children make older people happy? Do children meet the emotional needs of older people? So there's general and specific. Some older people don't like children. Okay, some older people like. So generally, a lot of older people, especially the ladies, they do enjoy watching children play. And it's something that triggers fond memories generally, but of course everybody is different. So for that reason, older senior center, childcare center, co-locating together is actually very good. Yeah.
Thank you, Dr. Ng. So we've come to the end of our session today. So once again, I want to thank Dr. Ng Wai Chong for sparing the time to give this very wonderful presentation. There's so much positive feedback that has come in the private chat message to us. So thank you, Dr. Ng, and we will hear from you again soon.
Okay. Thank you.